should be there, right?
All set.
I'm going to get started here. Thank you for coming. It's a topic that everybody knows is near and dear to my heart, so I'm glad to be able to share some of this with you guys. I'm going to try to finish up a little early today. Christopher Regan has some information for us on the pharmacogenomics program here at Yale New Haven Hospital. So we'll go through those slides at the end. So I'd like to start with a case. This is a man that I see at the VA, 76 years old, very active. Only hyperlipidemia and hypertension, colonic polyps, and some disc disease. It's first presented with unstable angina to us at the West Haven VA in December of 2015. And he had a relatively focal right coronary artery lesion that you see on that one freeze. He got a 4.0 Taxus stent, or not Taxus, 4.0 drug-eluting stent in 2015. Came back in 2016 with the same lesion. 2017, which I think this was at Danbury Hospital. Again in 2017 at Stanford Hospital. 2018 again at the VA, and then December of 2018 again at the VA with the same focal in-stent restenosis. So this is a problem that we don't see that much, and certainly we don't expect to see it with drug-eluting stents. This is just the punchline from the Sirius trial, which was the pivotal trial for the first drug-eluting stent that was approved by the FDA, showing that event-free survival was 91% at 9 months compared to the bare metal stents, which was 78%, and that's kind of what we expect when you use drug-eluting stents. If you look at the target lesion revascularization rate in the Sirius trial was 4%. The standard stent group was 4 times that. And the statistic that I always remember from this study is the angiographic binary restenosis rate was 3.2%. That's a term that we don't see too much anymore in interventional trials. But all these people had angiography at 9 months, I believe. And if you just look at the stented segment, the presence of 50% or more restenosis defined it as angiographic restenosis. And in that trial, angiographic stenosis was very low at 3% and really blew away the bare metal stents. So drug-eluting stents are very powerful. We all understand that. And it kind of eliminated the problem of restenosis. And I just want to go through restenosis graphically to remind everybody of exactly what we're speaking about when we speak about restenosis. If you take a plaque-filled artery and you dilate it with a balloon, there's cracks that develop in the intima, but you get luminal expansion, but we also get arterial expansion and stretch. And restenosis in balloon angioplasty is primarily mediated by elastic recoil as the artery shrinks back down to its normal dimensions. And the amount of intimal hyperplasia is actually relatively limited in balloon angioplasty restenosis. Stents, however, had a great impact on restenosis because they were able to scaffold open that arterial stretch that we accomplished with balloon angioplasty. So once we enlarged the entire artery and fractured the plaque, we had a scaffolding here to maintain that luminal dimension. But now the difficulty was that intimal recoil went away, arterial shrink went away, but intimal hyperplasia now became the dominant method of loss of the arterial lumen. So the methods of restenosis were changed pretty dramatically by stents, and drug-eluting stents were designed to tackle that problem, and they tackled it fairly effectively. Just to remind you that as you do angioplasty, you subject the artery to injury or barotrauma. There's a layer of platelets, leukocytes are attracted. There's a number of growth factors and cytokines that become activated, and they work on smooth muscle cells, which are in the media of the artery, and that's very important to understand the location of those cells that are going to be responsible for in-stent restenosis. And those smooth muscle cells proliferate, they migrate toward the surface, toward what becomes the intima, and they secrete matrix, which becomes the in-stent restenosis tissue that we see on angiography and ultrasound. And this is, a similar right coronary artery to our patient. They had a proximal stent. The limits of the stent are demarcated by these red arrows, and there's a very narrow lumen there, which caused the patient to represent with angina. If we look by ultrasound, we can see that stent is not expanded as large as the artery. Maybe it's a little bit underexpanded, but it's filled with this neointimal hyperplastic tissue, and by pathology, this is what we would expect to see. OCT and IVUS have given us great insights into restenosis and the mechanisms. OCT very clearly delineates 2 layers of stent in this particular patient, and we can see that the stent is expanded here, much like the IVUS, and the narrowing of the lumen is, in this particular patient, predominantly related to intimal hyperplasia. In other patients, we're surprised that the stents, in this case, there's 3 layers, are relatively underexpanded, and there's less of intimal hyperplasia. So the 2 main mechanisms are stent failure or stent underexpansion with or without significant intimal hyperplasia. So in the bare metal stent era, Ron Waxman, when he restenosis, understanding restenosis was really a major scientific undertaking in those days. This is a pig injury model with neointimal hyperplasia. And in this graph, Waxman showed the effect of low-dose radiation localized to the artery wall control. And I would bring your attention to intimal area. That's the black bars. 3.5 gray actually kind of increased the intimal area, but doses above that, 7 gray delayed by 48 hours after the injury, or 1.4 gray really reduced the intimal area in this pig model. And based on this animal data and some other animal data, this was brought to the clinic. The rationale being that in-stent restenosis is a proliferative response. It's not malignant, but it is cells dividing and moving, and it was analogous to keloid scar, heterotopic bone formation, or desmoid tumors, which are other non-malignant proliferative biologic processes, and the radiation proved effective in the animal models of arterial injury. So Paul Tierstein at Scripps kind of brought this first to clinical practice with the Scripps study, 5 patients, a mean of 2.5 prior restenosis events, so 3.5 prior angioplasty procedures, and 30% had diabetes. Not everybody had in-stent restenosis. Some of them were balloon angioplasty restenosis. They used iridium as their source of radiation, which is a gamma emitter. And their target was 8 gray to the farthest target distance. And again, the target is the media, and 30 gray to the nearest distance. And they had a source that was either 19 millimeters or 35 millimeters long. And this is their Kaplan-Meier curves of follow-up. You can see that event-free survival was reduced to 15% of people had prior events by 20 months as compared to 50% in the placebo arm. So the placebo was not surprising, but it was really dramatic that radiation had this kind of a beneficial effect in this very small study. And that effect was persisted at 5 years. This is their 5-year follow-up data showing that the curves stay apart. The radiation group continues to have events, but the treatment effect of radiation is persistent at 5 years. And very quickly, that led to a lot of industry interest in this potential treatment. And I'll highlight 3 of the many randomized trials that went on in the subsequent period. Gamma-1, which used an iridium source. Inhibit, which used a beta emitter, phosphor-32. And then the START trial, which used strontium as the source of a beta emitter. And this is the device that we still have today. It's kind of lasted all those years, but let's go through some of the data on these. Gamma-1 was multi-center and randomized, and 250 patients. And the endpoint was angiographic binary restenosis. Again, that term that we don't see too much anymore at 6 months. And you can see that although there was still a significant number of patients who reached that restenosis endpoint, it was much better than placebo, statistically significant. And nuclear target lesion revascularization, it was also reduced significantly. And by 9 months, the MACE rates were relatively low for this group of patients with refractory bare metal in-stent restenosis. Similarly, Inhibit, now up to 332 patients randomized. The dose was 20 gray, and they actually tried to reach the media with that dose. They used a P32, which is a beta emitter. And again, the results are very similar. A significant reduction in restenosis by angiography. Target lesion revascularization at 9 months was very low in this particular trial, and the MACE rate was about half of those treated by placebo. So very striking results in this particular era with so much restenosis. And then finally, the Novoste Beta-Cath device, which is the device we're using now. We're to almost 500 patients in this randomized trial, 8-month angiographic follow-up, and they had 2 dose prescriptions depending on the size of the artery that was treated. This particular device had the advantage of being relatively small, handheld. The sources were contained within this lucite plastic transfer device. The delivery catheter for each patient could be plugged in easily, and the source is delivered through that delivery catheter. So this is a really sleek design relative to the other 2 devices that were out, and picked up very easily and quickly. This is the current iteration of that device. The original delivery catheter was 5 French. It's now down to 3.5 French, still bulky, but a little friendlier than what we were using in 2000. And the available source trains at that time and still today are 30, 40, and 60 millimeters. And this is what it looks like when it's in the coronary. There's non-radioactive opaque flanking markers on either side of the sources, and you can see in this one frame the sources are in between there to deliver the radiation. And this is a stent that I had shown you earlier, which had in-stent restenosis, mostly in this segment of the stent. And here's that data from the START trial. 8-month angiographic restenosis was, again, very significantly reduced compared to placebo. If you just looked at the stented segment, it was very low, 14%, TOR very low, and MACE very low relative to placebo. So very consistent data in all 3 of these clinical trials. If you look at target vessel revascularization, all of them reduced it by about a third. If you looked at MACE rates, again, about a third, um, with a variety of sources and treatment prescriptions. What about the highest risk subgroups, diabetics, lung lesions, vein grafts, renal failure? It turns out that it was perhaps more effective in those high-risk subgroups. This is a sub-study from Gamma 1 looking at just the patients with diabetes. And you can see the restenosis rates were in fact lower if you just looked at diabetics compared to non-diabetics, which makes some sense as the proliferative response we think in diabetics is higher based on a number of factors related to diabetes and vascular biology. If you look at long lesions, again, the treatment effect was at least as good as shorter, more focal lesions, perhaps better. And vein grafts, when you look at the stent or the entire vessel, again, it was at least as good, if not better, than the native vessel effect seen in the randomized trials. So this is all very powerful data that, I think I have, chronic renal failure as well, target vessel revascularization or restenosis very significantly impact in terms of treatment effect in this very high risk subgroup. So the clinical trials were very encouraging uh, in these patients, and it was adopted very quickly. Long-term outcomes, looking for any potential safety signals. A 5-year study from Venezuela, the Scripps had 3-year, and Washington Hospital Center had 4-year safety data. All of them showed no signals in terms of aneurysms or other treatment effects, which we were worried about in terms of delivering radiation to coronary arteries. We very quickly were involved in this. We started doing investigational cases in '98. The FDA approved 2 devices in November of 2000, and we did our first commercial case in April of the following year. And we actually, Ken Roberts in radiation therapy and myself put together a little program and got some funding from the hospital to develop this as a program. And very quickly, our case volume took off. At its peak, we were doing between 15 and 20 cases per month. These are monthly figures. And then in December of '03, our case volume dropped like a stone because drug-eluting stents were approved for general use. And as you could expect, the drug-eluting stents really impacted in-stent restenosis as the trials would have predicted. I think we were very excited to have participated in this. We had been involved in 5 clinical trials, and we certainly believed that the therapy was effective and had some utility, but drug-eluting stents basically eliminated the market. I'll just show you some of our institutional experience. We had 8-month follow-up on 145 patients. A third had diabetes, a third had prior CABG, and a minority with renal failure. And you can see at 8 months, our repeat intervention rate was only 10%, whereas in this group, you'd expect a 30 to 50% reintervention rate. And any MACE was about 22%, which is very similar to the clinical trials. So our outcomes, our experience was very similar to the randomized clinical trials back in the early 2000s. Brachytherapy failure still happens in about a third of cases. This is a case done in the current era of brachytherapy. This is a patient with a stent which had been placed in the second marginal. You can see it's totally occluded. This actually fills by a collateral from a more proximal marginal. You see the distal artery here, but the in-stent segment is completely occluded. So after angioplasty to that treated that stented segment and then radiation, this is the final result at the time of the brachytherapy procedure. And about 6 months later, the patient came back with recurrent symptoms. And you can see interestingly, that the stent is quite um, patent, but the edges, the margins proximal to the stent and distal to the stent have restenosed again. So this is a very typical pattern of brachytherapy failure. Um, we took a total occlusion, and now we've kind of created these new two lesions here with restenosis. We were very interested in the early 2000s and why people fail. We were very interested in specifically in dosing, which of course in any radiotherapy procedure, dose matters, and the target receiving the dose matters. We were aware that there was quite a degree of variability in dosing from animal studies and our own experience clinically. And the current dose prescriptions used at that time and still are very empiric and weren't specifically targeted to the patient and the lesion. And there were different radiation systems that we were using there with different isotopes which had very different dose distributions. This is from our own radiation physics um, guys here at Yale that shows that dose distributions of the different systems available at the time, from the gamma emitters to P32 beta emitter, are quite different depending, and the dose drop-off curves are quite steep for beta emitters compared to gamma emitters. The current device uses strontium yttrium, which is this curve here, these curves here, which has kind of an intermediate uh, dose dose steepness curve, but it's still important to understand these as you look at an artery and try to decide what part of the artery gets what dose. The doses were very variable. Scripps 1 had used 12.82 gray at 2 millimeters from the source, and this is obviously an estimate. Rist and Gamma 2 had used 14 gray. START had used 2 dose algorithms, 18.3 if the artery was 3.4 millimeters or lower, and if the artery was 3.4 millimeters or larger, a 23 gray at 2 millimeters from the source. Inhibit was the only trial that tried to actually deliver a specific dose prescription into a level of the artery wall and did not make it relative to the source. I just have a couple of graphics to kind of illustrate how difficult dosimetry is in this. This is a perfectly symmetrical artery. It's 3 millimeters in diameter. So the radius is 1.5 millimeters. If we assume a perfectly symmetric intima of 1.0 millimeters, that means from the source center to the target, which is the media where the smooth muscle cells are, that's a 2.5 millimeter distance. And if you use the dose algorithms as prescribed, that would give 12 gray using the Novoste device. An iridium source would give 11 gray, and the P32 system from Guidant would have given 20 gray at the media. If we take a 4 millimeter artery and use the dose algorithms, that changes. The radius is now 2 millimeters. We assume the same perfectly symmetric 1 millimeter intima. That gives us 3 millimeters to target, and it really drops the dose in all three devices at the target. If we take a 2.5 millimeter diameter artery, now the source to target distance is 1.75, and the dose is extremely high for the P32 source. The strontium yttrium is up to 22 gray, and iridium is at almost 16 gray. And if we know life is not symmetrical, if we just vary one of the variables, and that is the thickness and the distribution of the intima, you can see, depending on where you are shooting for, either at the farthest distance, the closest distance, or an intermediate distance, the dose that actually reaches the target is highly variable. And then the final thing is, we know that when we put these sources inside the artery, it's not entirely symmetric. the source may be up against this part of the wall in one part of the artery, and depending on curvature um, and plaque distribution, it may be here at another part, so that this part of the artery gets a very high dose, and this part or this part would get a very low dose. So we were very interested in how those distributions might affect clinical outcomes. Um, we used a nested case control study design to look at our experience between 2000 and 2002. And we used IVUS to kind of come up with our actual dose delivered in these sample patients that we had. The physics department helped us develop Monte Carlo simulations every 2 millimeters along the analysis segment, along the treatment segment. And we looked at minimum, maximum, and average doses at the media along that entire treated segment. And so if we look at a treated artery, there's the stented segment. We look at that segment, we can come up with where the target is. That's the media by IVUS. We can look at our shortest target distance. We can look at our farthest target distance, measure those distances using IVUS. And then we can plot using the Monte Carlo simulations what the dose would be at several shells, and we can figure out exactly what the dose would be at our farthest and what the dose would be at our nearest target. So this is very painstaking work, and we would come up with dose distributions along the target. There's the treated segment, there's our average dose. We have the highest dose and the minimum dose in this particular patient, and you see it's variable between about 9 gray and almost 16 gray for the highest dose. And so we used 28 controls and 14 failure cases to try to understand the relationship between those failures and successes, and we matched them based upon the type of radiation system that was used and the lesion type, whether it was focal, proliferative, or total occlusion. And this is an example of our data looking at average dose. It looks like quite a scatter plot. The red triangles are successes, and the black circles are failures. But when we looked at the minimum dose distributed, there was a clear separation with the exception of this one outlier. The failures all came in at kind of a lower threshold of minimum dose. And if we looked at the mean, it was quite different between the successes and failures. So you can see that the minimum dose at the target in the failures was 7.46, and the successes was almost 9 gray. So our conclusions were that dose mattered, and that current dose algorithms are pretty inconsistent and unable to account for the variability that we see. And this is not a unique observation. Other people understood that dose mattered. Scripps 4 randomized patients to the standard dose prescription versus a higher dose prescription and looked at 8 months to see if in fact this translated into a clinical difference. And you can see if you look at late loss by IVUS, the higher dose was significantly better in terms of late loss. If you look at restenosis angiographically, the higher dose was better. If you look at target lesion or target vesicle revascularization, higher dose was better. If you look at diabetic subgroups, the treatment effect was really dramatic with the higher dose compared to the standard dose. And lesion length was also impacted with the higher dose. And MACE rates, there was no change in hard endpoints like death. The overall MACE rate was lower in the higher dose. So the conclusion from the Scripps 4 study was that the higher dose was better. There was no increase in early or late thrombosis, sorry, and no other safety signals. So really, we felt it kind of proved that dose mattered and that we didn't really have the correct dose algorithms at the time. Of course, the other important factors to remember about brachytherapy failure is use of new stents and the duration of antiplatelet therapy. At the beginning of brachytherapy, antiplatelet prescriptions were 30 days, and we very quickly learned that was not a great idea. This is a slide that Alexander gave me from the Washington Hospital experience, looking at the use of new stents and subsequent thrombosis events in the treated segment. And you can see that if you did not use a new stent at the time of your brachytherapy procedures, subsequent thrombosis events were very low and similar to kind of non-brachytherapy cases at that time. But if you used a new stent at the time of your brachytherapy procedure, you really up the ante in terms of risk of stent thrombosis later. This is another side that also kind of examines that same effect in gamma 1, gamma 2, and Scripps, looking at antiplatelet duration, whether it's 8 weeks or 6 months. And you can see if you drop the number of new stents implanted and lengthen your antiplatelet therapy, then stent thrombosis rate went from in the 6s down to 1.2%, which is kind of background and similar to stent thrombosis rates at that time. Similarly, in the beta emitters, these are all gamma trials in the beta emitters. Stent implants were relatively low, but antiplatelet therapy increased to 6 months, dropped thrombosis rates very, very low. So those two lessons from the early days of brachytherapy, we still believe are important, and we try to avoid new stent placement. There hasn't been any new trials in brachytherapy in the current era, but I just point out this one case series from Minneapolis showing a contemporary brachytherapy database, 116 patients, 143 lesions who were treated with brachytherapy. The reference vessels were about 3.5, and the average dose with the current dose prescription algorithms would be in the 20 to 23 gray range. And the 2-year event rates are still about 30% target lesion revascularization. Stent thrombosis is very low at 2%. And interestingly, the use of IVUS at the time of brachytherapy is associated with a lower risk for target lesion revascularization, 14% versus 40%. This is an observation that was made in the first kind of era of brachytherapy, that intravascular imaging with either OCT or IVUS really improve long-term outcome in brachytherapy cases. And certainly we believe that's still the case, and we try to use OCT quite frequently. Just a point about what about drug-eluting stents for in-stent restenosis. This is one of the several trials that randomized people between brachytherapy and drug-eluting stents in the early phases of drug-eluting stents, and you can see the outcomes with restenting are better than brachytherapy. So I think first episodes of restenosis at that time and currently are still best treated with another drug-eluting stent. Certainly the stent platforms are better and thinner, and it's easier to kind of re-implant a stent in your first episode of restenosis. So I just put that there. That data is there in the Taxus 4 trial and other trials from the mid-2000s to kind of validate that in-stent restenosis should not universally be referred for brachytherapy, but another layer of stent is appropriate in almost all patients. I want to bring you to the current, this is data from the National VA Registry of Interventions. Again, it's not quite contemporary, but it shows you that this is the number of cases being done for in-stent restenosis. So it's accelerated over the years. It's now approaching 8 or 9%, and I would argue that this is probably in the current area now, 3 years later, getting close to 10% of cases as the complexity of angioplasty increases, and the number of patients with ISR will also increase. Recognizing that trend, we kind of got the band back together, and in January of 2019, we restarted our brachytherapy program. In the 2 years or so since then, we've treated about 110 patients. We had a big slowdown during the pandemic, but we picked back up again. We have it's a fairly large team of people who are involved. The physicists are very important in terms of helping us do our dose algorithms. Radiation safety has to transport these sources throughout the hospital. Our colleagues in therapeutic radiology, Ken Roberts and James Hansen, excuse me, help us with dose prescriptions, and they actually do the treatment. And then Glenn Henry, Mike Clement, and myself have been doing most of the cases. We're trying to drag Samit Shah into this area as well, because the rest of us are getting a little old and ready to kind of move it on to some of the younger guys. And the cath lab staff has been great. These cases are long and often very complicated and involve a lot of ancillary equipment. And so it's a real team effort to get these cases accomplished. Our current procedure is we tend to use 7 or 8 French femoral access. The brachytherapy catheter does fit through a 6. It's a tight squeeze. It is pretty bulky to deliver, and I think we had a couple of experiences early on where we were frustrated with radial access and 6 French guide catheters. So we do tend to upsize and use me or laser. 100% we use intravascular imaging. We favor OCT for a number of reasons, but that's not always possible, and so IVUS is certainly acceptable, but at 100% you need intravascular imaging. You really need to make that are in there, and sometimes it's 2 or 3 layers are fully expanded, and sometimes you need laser, or more recently we've had experience in a few cases using lithotripsy to help us expand those previously placed stents, and we do avoid new stent placement as long as possible. We do recommend long-term antiplatelet Plavix for at least the 9 months or a year. There's no clear answer on when you can stop antiplatelet therapy, but as long as possible, we recommend people continue with Plavix. So this is our case that I started our talk with. It's a relatively focal lesion here in an area that has at least 3 layers of stent. We started by dilating with an NC balloon and used OCT, and you can see that the stents are quite underexpanded. I think the minimal diameter here was 1.9 millimeters. So we elected to use laser with contrast injection to try to get us to soften up that area and expand it. And we used, there was a 3.5 millimeter distal reference by OCT, so we used a 3.5 millimeter non-compliant balloon and ended up treating a 40 millimeter segment using a dose of 24 gray at 2 millimeters from the catheter. This is the OCT after laser and balloon expansion. And I don't know if you can see, but our dimensions are now 2 millimeters by 3.4 millimeters. So still somewhat asymmetric, but it was certainly better than what we started out at in terms of the area. This is the longitudinal representation of the OCT, which shows you the narrowest area, and this is the stented area. So that was our final result, and that was in January of 2019. About a year or 14 months later, the patient came back with some anginal symptoms and did not have a stress test, but went right to angiography. And this is the angiography about 14 months after his brachytherapy treatment. So we're not out of the woods yet. It's still a little early to claim victory, but certainly in this patient who had had multiple areas of multiple episodes of almost annual angioplasty to this segment, we were pleased to see that there was a stable angiographic result. So in summary, I think, in-stent restenosis is increasing in frequency. We're doing more and more aggressive procedures appropriately, and more complex procedures. And I think we're just going to see more in-stent restenosis. I think brachytherapy is effective, and it's one kind of bullet in the gun of things to manage patients with in-stent restenosis of drug-eluting stents. We believe that dosimetry is important and it still is relatively crude and deserves some refinement. I think that the randomized control data demonstrates improved outcome using higher doses, and certainly here at Yale, we've been defaulting to using higher doses, particularly when patients have 2 or 3 layers, or when we can see calcification on OCT. Those are things that are known to attenuate beta irradiation, which is the radiation device that we're using currently. And we know that there's no demonstrated loss of safety with those higher doses. I think there's a lot of unanswered questions regarding this therapy and its most appropriate use, but we are fully engaged and believe it's a good thing to do. So I'm going to end there. It's 8:15. If anybody has any questions, I'd be happy to take them, and then I'll switch over to Christopher's slides. Thank you.